Welcome to world number 3 of Power Up Endo's 90-day Super GP course. I hope you got a ton of value out of the single-rooted premolar live case demonstration. In this lesson, we're going to discuss the Power Up Endo method, and we're going to go into a deep dive as to what that is, what the framework is that I'm presenting to you, and I'm going to go over some value-packed information for each of those steps so that you can power up your endo game and become a 90-day Super GP. Again, here you are, and the first step that we're going to be performing in order to successfully complete routine endodontics in your general practice is the administration of bulletproof anesthesia, right? So I have a whole world dedicated to bulletproof anesthesia with step-by-step instruction. One of the key components of administering bulletproof anesthesia is what you're actually using and the chemistry that you're using in order to achieve bulletproof anesthesia. And so, like I mentioned in great detail, I highly recommend the utilization of Septicaine for your anesthetic of choice. Now, that's obviously assuming your patient has no contraindications to epinephrine, so you'll want to be mindful of that. If they do, then you're going to go ahead and use carbocaine as your alternative. It's very important that you use the chemical that's going to give you the most profound anesthesia, especially when you're performing any kind of invasive dental procedures. It's one thing if you're, doing shallow restorations that are maybe, a half a millimeter to a millimeter in depth, but once you're getting deep into the core of the tooth, you need profound anesthesia, and I have found that Septicaine is going to give you a much more profound level of anesthesia over xylocaine, and that's backed up in the literature as well. So once you've achieved your bulletproof anesthesia, we're going to proceed to achieving airtight rubber dam isolation. So I have an entire world dedicated to achieving airtight rubber dam isolation. So I'm going to go over that in great detail in that world. But I want you to know that single tooth isolation is really all you need for the majority of your endodontic cases. Now, granted, if you have a severely broken down tooth or a tooth with a lot of interproximal caries, and even sometimes crown prepared teeth, then you may want to utilize a split dam where you're going to punch 2 holes in your rubber dam, you're going to clamp the tooth that is distal to the one you're working on, and then you're going to stretch the rubber dam material over to the one tooth mesial to the one you're working on. All right, so it's a 3-tooth isolation. You're going to floss down the rubber dam over the mesial contact of the most mesial tooth, and you're going to have a nice, solid, airtight rubber dam isolation. Now, in these situations, I would highly recommend that you block out all the gingival tissues utilizing ultra dense opal dam grain material that you're going to light cure, and I'm going to demo that for you. But that's going to give you a nice airtight seal, even though you have this, large opening in the rubber dam. Also, you really don't need to get crazy and complicated with which clamps you're going to outfit your practice with. All right, 99% of the time, these 4 clamps are going to be all you need in order to isolate any given case. All right, what I want you to reach for is the clamp 13A for the upper right and the lower left, the 12A for the upper left and the lower right, the 2T, that's going to be your universal premolar clamp for all your premolars, and then finally, obviously, your 9 or 9T, if you want the serrations, for any anterior tooth, including canines. That's going to be all the clamps you need in order to perform 99% of your endodontic cases. I wouldn't get too crazy. It can get very complicated and very costly to outfit your practice with a ton of rubber dam clamps. It's unnecessary and it's wasteful in my opinion. And then once you've achieved your airtight rubber dam isolation, then we're going to perform our caries control. All right, so you want to remove all caries before you initiate the actual endodontic procedure and get into the pulp chamber. Definitely not deep into the endodontic procedure. You want to make sure you have a clean area that you're working with. You don't want any of that bacteria in the carious lesions to get into your endodontic spaces where you're working so hard to disinfect that space and get everything nice and clean. Also, you want to get to sound tooth structure so that you can determine whether or not you have any major cracks. All right, that's going to be super important because sometimes if you have large existing restorations or carious lesions, you can't really visualize too much the extent of any cracks, and you want to screen for that before you proceed with your endodontic procedure. You don't want to get really deep into a case and then discover, oh, look, there's a crack here, and maybe the tooth doesn't have a good long-term prognosis, and we're going to abort the procedure. You want to find out those kinds of things very early in the procedure so that the patient isn't undergoing anything unnecessary, number one, so you're not wasting chair time. I know, granted, you probably allotted some time for this patient already, but let's be real, there's always things around the office that we can do. Return phone calls, discuss with our front desk staff, possible modifications of the schedule because of that. And so you want to discover these things so that you're not wasting so much time in a case that maybe is not a good long-term situation for the patient. And once we've achieved our caries control, okay, then we're going to get into our access preparation. And that's really the key to the entire endodontic procedure. If you do this right, it's going to set you up so that you have a successful outcome and you have a stress-free procedure. So you want to take your time with access preparation. So step one, I want you to lower the occlusion on the tooth that you're working on, unless obviously you're dealing with a crowned tooth, in which case you can't do that. But like I mentioned in the case demonstration, lowering the occlusion is going to give you a stable reference point for your instrumentation, number one. And number two, it's going to reduce some of the post-operative sensitivity your patient is going to likely have during the healing period. So lowering the occlusion is always a good idea. Also, in terms of the burrs that you're going to use for your access preparations, so the lowering of the occlusion is well done with a chamfer diamond that every dentist has because of their crown preparations usually. And the majority of the access preparation is going to be done with surgical length round burrs. And the sizes that are most universal and best are going to be sizes number 2 and number 4. All right. Obviously, if you have a molar with an insane carious lesion, you might want to have some larger round burrs. But for the endodontic procedures, sizes 2 and 4, surgical length round burrs are really going to do the trick for the majority of the time. The reason that surgical length is so important is because it allows you to see much better so that the head of your handpiece is not blocking where you're looking. The extra length allows you to look very precisely as to what you're prepping, as opposed to having the head of the handpiece in your way. So I'd highly recommend surgical length round burrs. And then in terms of refinement of your access preparation, that's best accomplished, in my opinion, with what's called an Endo Z burr. This is a non-end cutting burr, and it only cuts with the barrel of the burr, and it's very, very useful for smoothing out your axial walls internally. So I'd highly recommend that burr just for your refinement after you've located all your canals. Now, in terms of anatomy, we're not going to go deep into the minutia of anatomy, but it's important to understand, what kind of configurations to expect. So Dr. Vertucci in the 80s did a landmark study where they sectioned hundreds and hundreds of teeth to present what the different anatomical configurations are in terms of the endodontic anatomy. And luckily for us, while there are all these possible configurations, the majority of the time, you have one of these 3 situations for a given root. You have Vertucci type 1, single canal with a single exit point. Vertucci type 2, 2 canals with a single exit point, so a 2-1 configuration. And then Vertucci type 4, 2 canals with their own exit point, their own apex. And like I said, this is the majority of the cases that you'll see out there. And luckily for us, they're also the most easy to treat configurations of all the different types. I want you to be mindful of different configurations, and we're going to go over each one. Now, luckily for the maxillary arch, okay, in terms of anteriors, we almost always have a single canal that we're working with. Now, with maxillary first premolars, okay, usually you have two canals you're working with, all right, about 69% of the time. Maxillary second premolars usually have a single canal, okay, about 3/4 of the time. And then we start getting into the more complicated teeth, obviously. So our maxillary first molar, the distal buccal and the palatal roots are usually a single canal configuration. So that's not what you want to worry about. But obviously it's the MB root that has the more complicated anatomy. So the MB root, 45% of the time, has a single canal. You love those. Those are the easiest to treat, obviously. 37% of the time, there is an MB2, but it's going to merge with your MB1. It's critical always that you find all the canals, but when you have a merging MB2, especially for vital cases, you have a chance if you happened to miss the MB2. I'm not advocating for that. I'm just saying the tooth has a chance long term. In a necrotic case, I can almost guarantee the case will eventually fail if you don't treat the MB2 and it's a merging canal or a separate apex. And 18% of the time, you have an MB2 that has its own apex. So obviously, those are extremely critical to find, because if you don't, again, you're probably setting the case up for failure. And then with our maxillary second molars, they're a little bit more forgiving. All right, so the MB root of those, about 71% of the time, have a single canal. 17% of the time have that 2-1 configuration. So that leads us to about 88% of the time at the apex, you only have a single exit point. And then finally, 12% of the time in the MB root of maxillary second molars, you'll have a separate, you have an MB2 with a separate exit point. So those are obviously the most critical to find. But you know, MB2 is always critical to find. But like I said, you have a shot if the case is vital and you can't locate or instrument that MB2. You have almost no shot if it's a necrotic case. And these numbers have been discovered to be slightly higher in terms of prevalence of MB2 in more recent studies. But this was a landmark study that we used for anatomical statistics for a long period of time. And so it stood the test of time. So I would recommend having these kinds of numbers in mind. And then with mandibular teeth, okay, luckily the mandibular anteriors almost always have a single canal. The mandibular first premolar, about 1/4 of the time, has a 2-canal configuration. Now, these are notoriously challenging cases, and I would be very, very selective and careful about putting these cases in your schedule, because even I struggle with these lower premolars with multiple canals. Sometimes they even have a 3rd canal, I've discovered as well. And so you want to be very, very selective, and luckily you have the luxury of being able to select which cases you want to tackle and which cases you want to send out. You know, obviously I don't have that privilege as a referral-based practitioner, you know, in terms of being an endodontist. You want to be very, very careful about packing your schedule with complicated stuff like lower premolars with multiple canals. I would be mindful of that. You don't want the aggravation, and honestly, it's kind of unnecessary. If you feel like you can handle it, that's one thing, but I would be very careful about putting these kinds of cases into your schedule. And then mandibular second premolars, usually have a 1-canal configuration, almost always. Now, once we get to the mandibular first molar, we have a situation where the mesial root, about 12% of the time, has a single canal, and I love when those show up in my schedule. Oh, those are the best. Those are the fastest cases, of any posterior tooth, in my opinion. And then 28% of the time, there's a 2-1 configuration in the mesial root, where the MB and the ML canals will join into one. All right. Now, very important. These joining mesial root canal configurations are the #1 site of instrument breakage. Oftentimes, an improper or an inadequate glide path is prepared with hand files, and then rotary instruments are introduced and kind of forced down, because what happens is the mesial buccal canal will oftentimes merge with the mesiolingual canal, and that point at which it merges is a very, very frequent site for instrument breakage. So it's super important that for the mesial roots of lower molars, as well as the mesiobuccal root of upper molars, you're meticulous with your glide path preparation, and I would encourage you to at least open up to a size 15 hand file before you introduce rotary files, because that's going to give you a nice path for your rotary files to go down so that you're not having to push on the files. The files, you got to take what the tooth gives you. And if the tooth is not giving you a continued path with your rotary files, then you're going to go back to your hand files and work them up to a bigger size and make more room for your eventual reintroduction of your rotary files. And then 59% of the time, those MB and ML canals are going to have their own exit point. The distal root canal of lower first molars, 70% of the time has a single canal. Granted, it's usually in an oval shape. And while it's nice to have a single distal canal for your lower molars, because of that oval shape, oftentimes, you have to be mindful that your instruments are circular in shape and the canal is oval in shape. So if you introduce a circular instrument into an oval canal, clearly it's not going to debride it optimally. And so what I would encourage you to do is on your in stroke, you're going to proceed apically. And then on your outstroke, I would encourage you to brush the walls, usually in a buccolingual orientation, so that you can debride that oval-shaped canal with your circular instrument. If you just peck in and out, in and out, in and out, you're not going to fully debride that oval-shaped root canal. And then about 30% of the time, you have some sort of two-canal configuration, half of which are a merging situation where your DB and your DL canals are going to merge into one. And in the other half of those times, you'll have a DB and a DL canal that have their own exit point. Mandibular second molars are, again, a little bit more forgiving, where a quarter of the time, approximately 27%, you have a single canal. And then, a little bit over 70% of the time, you have a two-canal configuration in the mesial root, where the half of those, you have a 2-1, and then the other half, you have separate apices on that mesial root. And then the distal root usually has a single canal, about 92% of the time. All right, so in terms of access preparation, which is, again, the key to your endodontic procedure, the rule of symmetry is very important. And I'm going to show you a diagram to explain what I mean by that. But essentially, if you're looking at a root that has a single canal, you should have that canal centered in the tooth. If that canal that you've discovered is off-center, usually either buccally or lingually, then more often than not, you're going to have another canal there that you have to search for. There should be symmetry in terms of the anatomy, and I'll show you what I mean in a second. Also, straight line access is super important. So it's tempting to perform super conservative endodontics and perform what they call a ninja access, where you have a little pinhole that you have prepared and you're attempting to look for all these root canals through a little pinhole. Studies have shown that actually you don't really gain a whole lot of fracture resistance long term when you perform these tiny little ninja access preparations. And you're really just going to set yourself up for aggravation. So you want to perform an access preparation that's adequate, where you can see all the root canal orify. And you don't want to risk having procedural errors because you're trying to perform a tiny little pinhole access preparation. So I'm very sensitive to this because my research was on the topic of conservative endodontic access preparations, specifically how CBCT can help guide you with those access preparations, and that was published in 2018. Nevertheless, it's really reserved for specific cases, and I would not really encourage you to perform these, what they call contracted endodontic cavities or conservative, access preparations in your practices unless you have a ton of experience, because it's very easy to miss canals, it's very easy to perforate teeth, and it's very easy to not fully debride and disinfect the root canal spaces when you have these tiny little access preparations. Also, for anterior teeth, you got to make sure that you remove and unroof all the pulp horns so that you can get all that pulp tissue out. Okay, like I mentioned in the case demonstration, if you leave pulp tissue inside one of these pulp horns, it's very easy over time for the patient to have a discolored tooth. So I would encourage you to be very mindful of this, and everything should look nice and smooth and unroofed, especially for your anterior teeth. Okay, you don't want to have a patient who has a discolored tooth because you didn't take the time to completely remove all the pulp tissue internally. And this figure is really showing you the different type of access preparations that can be performed. So you can see very clearly that in figure number 2, that's a tiny little access preparation. That's one of those ninja access or contracted endodontic cavities. And you're going to drive yourself crazy trying to find all the root canals in this tiny little access preparation. I would not recommend you do that unless you're a very, very, very experienced endodontist who's been doing this for decades. But even still, there's no real reason to prepare an access that tiny. And then in figure number 3, that's something a little more conservative. That might be a shape that, you know, I might be striving for in certain cases, especially with a restorative dentist who just placed this crown. If it was a crowned tooth and didn't want the porcelain to chip, they might ask that I perform an access preparation in terms of this extensive opening. But again, it's more challenging and you have a higher chance of procedural errors. And then on the far right, that's more of the shape that I want you to be looking for and striving for when you prepare your access preparations. You can see the root canal orify, you can find your MB2 canals, assuming it's present, and you're going to have a much better time performing your endo treatments through an opening similar to this, and you're much more likely to debride the entire internal aspect of the root canal system. And this image really, really, really exemplifies what I mean by the law of symmetry. All right, so figure A shows us a lower molar that very obviously has 2 root canals. You can see that the 2 canals present, the mesial and the distal canal, are on the same plane internally, as opposed to figure B, where, for instance, the MB canal and the distal canal were discovered, and maybe we're not able to find a third canal. But you can see very clearly, okay, that there's not symmetry between the 2 found canals, and that dashed line is going to show you generally where the midline is, and the X is exactly where that ML canal should be. You don't want to stop here and assume that there's only 2 canals when you don't have that symmetry. And when you have a 4 canal configuration on a lower molar, if the distal canal that you've discovered is not in line with the midline of the tooth, then you know that you likely have a second distal canal because it's not symmetrical. Now, granted, you can have a very oval shape, but even after you've debrided in an oval-shaped canal, if it's a 1 canal distal root configuration, it should be centered. All right. If it's not, you got to look for a second canal. I would highly recommend you continue your search. So once our access preparation is complete, then we're going to move on to our canal identification. And you're going to obviously want to study your preoperative radiographs so you know what you're getting into prior to your endo treatment, okay? But once you've discovered your canals and you've pecked at them with your Endo Explorer, then you're going to use your orifice opener to open up the shape of those canals. And the orifice opener that I recommend is the ProTaper Gold SX orifice opener. And you're going to see that over and over in the live case demonstrations. But it's a nice orifice opener because it's nice and chunky, and it's going to get that initial shape that you're looking for in the coronal third so that you can flood the chamber with your sodium hypochlorite and really start to see what the final shape and your canal identification is going to look like once all the canals are found. And once you've identified all the root canals inside the case, then you're going to work on your glide path preparation and your working length determination. So what I want you to do, remember, our size is 8 and 10 hand files. I would recommend you buy C files. They're the same cost as your K files. They're just a little bit stiffer for those tiny little canals. But you're going to use a 10 file to determine your working length with your apex locator. And once you've got your working length measurements, okay, you're going to start preparing your glide path with your size 15K files. And you want that 15K file to go nice and easy up and down inside the root canals so that you know that your glide path is prepared and you have a nice smooth path for your eventual rotary instruments that you're going to be introducing into each canal. So the glide path is meant to really provide you a smooth and reproducible path for your eventual rotary instruments. And like I mentioned, I recommend the Lexicon hand files, sizes 8 and 10 in the C file, and then sizes 15 and above in K files. And the Lexicon files are nice because they come pre-sterilized in little blister packs. In terms of your apex locator, the most frequently used apex locator by endodontists, and it's really reliable, is the J. Merida Root ZX apex locator. And when you're obtaining your working length, you want to finish your instrumentation or obtain your working length to what you see here in the image, okay? That midpoint between the number 1 and the apex. That's going to give you a nice endpoint right at that apical constriction. And any file that you introduce into a case, hand file or rotary, I'd highly recommend you use a gel lubricant. And the gel lubricant that I would recommend is Premier's RC Prep. RC Prep is a very, very common gel lubricant. It's an EDTA chemistry that's formulated in a nice thick manner so that you can use it as a gel. Now, the C files, like I mentioned, are special heat-treated files that have increased stiffness and strength and are really nice in those small file configurations, okay? So I would recommend the C files. And anytime you introduce a file into the root canal, especially hand files, you want to place a little pre-bend on the tip of the file, just like you see here. So you can just bend the tip of the file on the mirror that you're holding and just I use my left hand to just give it a little subtle bend at the tip. That's going to allow you to introduce the files into the canals much more easily than having something that's straight, and it's going to allow you to see better as you do that, so you can ensure that you're putting in the hand files into the canal that you think you're putting it into, okay? So a subtle little bend is always a good idea for any hand file that you put into the patient's mouth. Like I mentioned, C files sizes 8 and 10, and K files in sizes 15 and above. Once we've got our glide path and our working length from our apex locator, okay, obviously we're going to take our working length radiograph, but then we're going to proceed to our instrumentation phase of the treatment. Now, I have a whole bonus stack on different kind of rotary files and what you may want to consider when choosing a system for your practice. I personally like the Dentsply Vortex Blue O4 taper rotary system. It's a special heat-treated file that's extremely flexible, and the beauty of one of these universal systems is that they work for basically any case that comes your way, because you have ISO sizes 15 to 60 essentially, all right, for a rotary file, and this gives you the practicality. It's somewhat of an open system, so you don't have to buy different systems for different cases. You may want to. I wouldn't necessarily recommend that. I don't do that, but it's nice to have an open system that you know will work on any case that comes your way. Now, this diagram really nicely illustrates the anatomy of a root canal itself, and you want to finish your instrumentation at the minor apical diameter. You can see that once you get past that point, the anatomy of the canal will flare out. But if you prepare right to that little constriction, okay, you're going to have a nice solid stop for your obturation materials, and you don't need to worry so much that you're over-instrumenting the case. It's also important to note that oftentimes these exit points are not at the very tip of the root itself. They could exit laterally, and that's exactly why sometimes your anatomic apex is not coincident with your radiographic apex, because the radiographic apex is going to show that at the very tip of the root is where the end point is. But sometimes you can have a exit point that's slightly lateral, and it might appear a little bit short on the radiograph, but it's actually the perfect perfect spot. So you want to trust your apex locator, and you want to use your common sense here, but don't get too hung up on getting a endpoint in terms of your root filling that's at the radiographic apex. Now granted, if it's 2 millimeters from the radiographic apex, that's one thing. Clearly that's not likely to be correct. But 0.5 millimeter short, if that's what your apex locator is telling you is the endpoint, I would not sweat. I would definitely go with that length. And once we've achieved our instrumentation and completed that phase of the treatment, then we want to really think about the disinfection phase of the treatment. And this is a great slide because it shows you how complex some of these root canal systems are. What they did is they utilized micro CT technology, and they scanned these teeth prior to any instrumentation. And that was a green color when they scanned them prior to instrumentation. And then they instrumented the teeth and scanned them again. And they were able to shade the instrumented areas with a red color. And when they superimpose those images, you get something like this, where the red color shows you all the surfaces that your instruments have actually debrided, and the green surfaces are the areas where it was not debrided. So on the left, we have an upper molar, and we can see how many little isthmus and deltas are present internally that your mechanical instrumentation is not likely to reach. And on the right, we have a lower molar. Okay, you can see the MB and the ML canal sometimes have this wide isthmus and all these areas that your instruments are not going to touch. And that's why your chemical disinfection is so important. So if you don't use sodium hypochlorite, which I have heard dentists tell me they don't use sodium hypochlorite, they just use either saline or xylocaine or something like that that's just going to give you a lavage and not an actual disinfection, that's not going to cut it. Your chemical disinfection is going to help you so that you can clean out all these areas that your rotary instruments are not touching. It's very important. And this is oftentimes the most neglected area of treatment, where you've done your mechanical instrumentation and you're ready to put some gutta percha down into the system. Take your time with your chemical disinfection. You can't see how well a tooth was chemically disinfected on your post-op radiograph, but it makes all the difference. You want to treat the tooth like a microbial culture. You have to be very careful to not introduce bacteria into the system, and you want to be very careful to make sure that you fully disinfected all the bacteria that's present in the root canal system. I would recommend diluting your sodium hypochlorite 50-50. So you have a half strength sodium hypochlorite. That's super important because you don't want to have any sodium hypochlorite accidents, and that's achieved by squirting your sodium hypochlorite into the periapical tissues. Now, a half strength is going to significantly decrease the chance that you have a sodium hypochlorite accident. I'll discuss that a little more in the complications section of the training program, but keep that in mind. You also want to have a lot of volume of solution. So don't be surprised if 10, 20, sometimes 30 milliliters of disinfecting solution is required to get a case nice and clean. Volume makes a huge difference in terms of disinfecting your cases. And then in terms of the sequence of irrigants, again, you don't have to get super fancy here, but generally you want to use your half-strength sodium hypochlorite throughout the case between every file that you take to length. And then in the disinfection portion of the treatment, okay, we're going to do a little more sodium hypochlorite. We're going to aspirate out the sodium hypochlorite. Then you're going to introduce 17% EDTA. And you don't need a whole lot of this. 3 milliliters or so is going to do the trick. But you want to get the 17% EDTA into the root canal system and let that soak for a full 60 seconds. Once the 60 seconds is passed, you can aspirate out by drawing it up with the syringe, your 17% EDTA. And then what that's going to do is that's going to remove the smear layer internally and unclog the dentinal tubules inside the root canal system. And then your sodium hypochlorite as your final rinse is going to penetrate into those unclogged tubules and disinfect even further than what you did thus far. So that's the sequence of irrigants in this phase, the very last phase before obturation. A little more sodium hypochlorite, draw out, 17% EDTA for 60 seconds, draw out, and then your last flush with a little more sodium hypochlorite, and then draw out. and that's going to get you right to the obturation phase where we'd start with our paper points. But that's the protocol that I want you to utilize in all your endodontic cases. Now, I'm going to discuss 1-visit versus 2-visit treatment in great detail in the bonus stack, but if you decide to split a case in two, I'd highly recommend you place calcium hydroxide, and you want to use something that's very, very user-friendly to operate with. I like Ultra Dense Ultra Cal XS calcium hydroxide. So you can squirt it right into the canal, although you want it to be a very passive fit with your needle, so you're not squirting calcium hydroxide into the periapical tissues, but you want to just backfill each of the canals with the calcium hydroxide and then place your temporary restoration and then reappoint the patient for their obturation visit, right? This is a great calcium hydroxide. I'd highly recommend it. Now, I went to the University of Connecticut for my endodontic training. My mentor is Dr. Cameron Safavi. He is the program director at the time, and he was the chair of the department as well. And he was really the one to bring calcium hydroxide to the forefront of endodontics. And his landmark study, which is very, very often cited, really showed how calcium hydroxide is not just antibacterial, but it actually degrades the LPS of bacteria. And he was able to show that and publish his work, and that really brought calcium hydroxide to the forefront of endodontics, and it made it very frequently used in endodontic practice. Fantastic, fantastic educator. I'm so lucky to have trained under Dr. Safavi. So that gets us to the obturation phase of the treatment. This is far less important than most people think. There's a lot of different forms of obturation, and we're lucky that we have different options, but I would highly recommend that you utilize the system that's the simplest, the quickest, and the most efficient, because the obturation is not the most important step of the treatment by any stretch of the imagination. Now, you first want to get the case in terms of each of the root canals nice and dry with your paper points. I would recommend you use ProTaper's F2 paper points. It's a universal paper point, and it's nice and chunky in the middle, and it's just going to get the case nice and dry with a single paper point per canal. But you want to make sure that you disinfect your gutta percha points with your half-strength sodium hypochlorite for 30 seconds before you bring that into the canals. That's going to make sure that the cones themselves are not bringing bacteria into this perfect system that you've worked so hard to get nice and clean. And you want to use a gutta percha cone that matches the rotary system. So if I'm recommending the Vortex Blue system, you want to use the matching gutta percha points. Now, granted, not all the time will the matching gutta percha cone fit to length. So what I often do, because of the sealer that I'm recommending you use and how it's actually quite thick relative to other sealers, sometimes you have to use a gutta percha cone that's usually one size, potentially two sizes down from the rotary file that you finished with in a given canal. So usually, in a lot of cases, I finish with a size 35 rotary file. So I will usually obturate with a size 30 gutta percha cone to fit in there, because of the sealer that I'm going to recommend in just a second to you is a little bit thick. And that sealer is Brasseler's Bioceramic BC Sealer. The BC Sealer is a fantastic, fantastic sealer. It's very user-friendly, and it's a technology we luckily have at our disposal in this day and age. Now, the utilization of the BC sealer, it's recommended that it be done under a form of obturation called hydraulic condensation. And it's effectively a single cone technique. It's a fancy way of saying a single cone technique. The beauty of it is that the sealer has such amazing properties. It's essentially MTA-like chemistry and a calcium hydroxide-like chemistry. But it's very, very simple to do, the hydraulic condensation technique. It affords us an unbelievable amount of control in terms of our working length, because we don't have to push very hard on the gutta percha cone in order to get this warm vertical 3D obturation. And then the sealer itself is very biocompatible to the tissues. So you don't have to worry about getting that gutta percha really hot and spreading it into all the nooks and crannies, because this is really a sealer-based obturation. And when you look at the cross-section of a tooth that's obturated in this fashion, we can see that a lot of the nooks and crannies are filled in by the white sealer that you see here in the various sections. And all you got to do is sear off the gutta percha right at the root canal orifice. I recommend using Kerr's System B heating element with the Buchanan heat pluggers in a size fine medium 08. That's like a universal size, and that's going to get you through basically all of your obturations, okay? And then when you do your compaction with hand pluggers, I would recommend the Buchanan pluggers sizes 1 and 2. That's going to cover you for basically all of your cases. The plugger that I reach for 95% of the time is the red one, the size 1, and they have a larger side and a smaller side to that size 1 plugger. And I use the larger of the red plugger, like I said, 90% of the time. For one of these really large cases, really large canal cases, you might want to use the size 2, which is the blue. For sometimes anterior teeth, I'll go ahead and reach for that. And once we've done our obturation, we're moving on to our restorative phase of our treatment. So if you're going to be temporizing your cases, you're going to want to use either Cavit for a soft temporary, or oftentimes I like to use a Fuji9 glass ionomer, which is a nice hard temporary restoration. It's going to give you much more strength out of your temporary restoration. And if there's going to be a lag between when the tooth is restored and when the endo is completed, I oftentimes will place this as the temporary restoration. And you want to place some sort of barrier. So you can use a cotton pellet, but I like to use a sterile sponge. So I just get a sponge, I cut it up into tiny little pieces, we sterilize them, and I utilize that as the barrier between the access preparation and the temporary restoration. Now, you have the luxury to decide whether you want to place a definitive restoration in this tooth at this point. And if you feel confident that the tooth is nice and clean and you're going to have a great outcome here, by all means, go ahead and perform your core buildup on the tooth, or a post and core buildup on the tooth. If you perform your post cementation at this point, in the event that something goes wrong, okay, you're going to have a much harder time dealing with it because now you have a post cemented in there. So you may want to, if you're going to perform a definitive restoration right after the endo is done at that same appointment, okay, you might want to only do that for the cases where you're performing just a core buildup. Because if you have a problem, granted, if it's, it could only be 1% of the time, all right, that's going to be a headache to have to deal with the fact that you've cemented a post into the root. So just take that into consideration. And there you have it. Jump for joy, your root canal treatments are completed. Your patient is super, super happy. They think you're the best. Okay, they're going to leave you a great online review, and they're going to refer all their friends and family to your practice. You can set them up for their crown appointment if you'd like, if it's a posterior tooth, or if you decide that that's necessary. Okay, that is the Power Up Endo method. It's the framework for all your endo cases. It's the backbone for this entire training program, and we're going to be utilizing it to work through every single live case demonstration. I will see you in the next lesson.